Right. Hello and welcome. We are at the top of the hour. Welcome to the ASLM special COVID-19 session number 6, an initiative of ASLM, Africa Centre for Disease Control and Prevention, FIND, ICVIA, the Korea World Bank, NICD. My name is Anafi Mataka. I'm the project lead for accelerating access to diagnostics and integration into national programs funded by Unitaid, as well as manage the laboratory systems, strengthening community of practice at ASLM. So by way of starting, since the declaration of COVID-19 as a pandemic, the whole world is in agreement that testing, I'll use again the term testing for the third time, is our main gateway to the victory of this fight against COVID-19. We know at the moment that the PCR test is the gold standard for case detection and confirmation. However, we also agree that there are concerns around its access. And many of us, including our governments, are eagerly waiting for alternative. Of note too, is that one paper actually put it in an interesting way that currently global regulators have largely stepped out of the way of diagnostic manufacturers to enable them to quickly bring in these COVID-19 tests. As a result, we have many of these testing options on the market. And in many cases, we are still wondering whether they are really reliable or accurate. This is a novel virus. Nobody can blame anyone. Indeed, we are all concerned that there is a rapid influx of these tests as has been coming up in all the previous sessions. Hence, as we saw it fit to have this session today to discuss the issues concerning this, what are the evidences for and against. So today we have a rich lineup of presenters and experts in the field. We will have Professor Rosanna Peeling from the International Diagnostics Centre at the London School of Hygiene and Tropical Medicine. She will give us a presentation, and we shall also have Dr. Yenew, head of the laboratory services at the Africa CDC, as well as Dr. Amadou Sall from the Institut Pasteur de Dakar. So without taking much time, a few reminders so that our session goes seamlessly, interesting. Please keep your microphone on mute when you're not speaking. As usual, enter your questions or comments into the chat box and we'll pick them from there. Without taking much time, I'd like to hand over to the first presenter today, Prof Rosanna Peeling, to take us through. Over to you, Prof.
Hello, everyone. I'd like to begin today by thanking ASLM for giving us this opportunity to discuss the role of diagnostics in the COVID-19 pandemic response, and in particular, the use of serology tests. Let's first look at how we normally diagnose viral infections. From the time of exposure till the onset of symptoms, there's usually an incubation period of 2 to 14 days. But with the onset of symptoms, patients tend to be shedding a lot of virus, and that's the time when you could use a molecular test to detect the viral RNA or DNA. And in the case of coronaviruses, it's the RNA. The period of viremia usually peaks around 5 to 7 days after the onset of symptoms. And with that, the RNA levels tend to decrease. During the first 7 days after onset of symptoms, we could also use an antigen detection test to detect viral proteins that are produced as the virus replicates. Although less sensitive than RNA tests, nevertheless, antigen detection tests give us a slightly longer window for the detection of viral infection. From about 7 days after onset of symptoms, patients will start to develop antibodies in response to infection. IgM antibodies are the first antibodies to appear, and they tend to persist for weeks, if not months. IgG antibodies will develop later, but they could persist for years. And so IgM and IgG antibody responses by themselves are not usually used as a way of diagnosing viral infections, but a fourfold rise in antibody titers between an acute blood taken during the first 7 days, first 14 days after onset of symptoms, till the patient has recovered a couple of weeks later. If there's a significant rise between those two samples in terms of antibody titers for IgM or IgG, then that gives us a definitive diagnosis for viral infection. Now, what do we know about the SARS coronavirus 2 in terms of infectivity and RNA detection? We know from studies that's been published, and also some that are published online but not peer-reviewed, that RNA can be detected perhaps 1 or 2 days before onset of symptoms, but can remain detectable up to about 25 to 50 days post-onset of symptoms, especially in patients that are not showing signs of recovery. Viral RNA levels typically peak within the first 5 days post-onset of symptoms and then decrease slowly with rising antibody levels. And in COVID patients, we found that RNA clearance is not always correlated with rising antibody levels, especially in those who are critically ill. There's a small study that showed that the viral messenger RNA was only detectable between 5 to 7 days post-onset of symptoms, but that an RNA test could remain positive for 1 or 2 weeks after the onset of symptoms. So that means having an RNA positive test doesn't always mean that you're shedding live virus. And what do we know about the immune response to COVID-19? We know that typically an immune response to viral infection takes about 40 days. And so in the two figures that I've shown here, taken from 2 different studies that are fairly big, the one on the left from clinical infectious diseases has 173 samples, and the one on the right has about 80 samples. And you could see that the seroconversion time is between 10 days and about 20 days. So on the whole, seroconversion is completed within the first 3 weeks post-onset of symptoms. And the mean time for seroconversion is typically for total antibody day 11 after onset of symptoms. For IgM is day 12 and IgG day 14 after onset of symptoms. And what do we know about neutralizing antibody responses to COVID-19? So we think of neutralizing antibody responses as a marker of protective immunity. And studies have shown that antibodies against the receptor binding domain of the spike protein of the coronavirus and the nucleocapsid protein are correlated with neutralizing activity against the virus. And so these figures that I've shown here from different studies that show that neutralizing antibodies actually start to be to rise in patients from about day 7 onwards, and reach very high levels by the time 2 weeks after onset of symptoms. The figure in the middle is from 6 patients who had the mild disease. And the figure on the right are specifically different responses that are for nucleic acid protein and this receptor binding domain of the spike protein. And you could see that, again, the antibody levels start to rise and peak around 2 weeks after onset of symptoms. Now, what is the, in terms of antibody responses in severe cases or mild cases, are they different? In the set of figures that are on to your right, we could see that if we follow 10 patients who have severe infection and 13 patients that have mild infections, you could see that the patients with severe infections normally would have very steep rises in antibody levels, especially against the nucleic acid protein, both IgM and IgG, and against the receptor binding domain of the spike protein. In the case of patients with mild disease, the antibody level seems to go a little bit slower in terms of development, but ultimately the levels they achieve are about the same. Some may be a little bit lower. And the figure to the right actually shows the viral titer in these same patients, and you could see that the clearance of virus from both the oropharyngeal cavity as well as endotracheal isolates are very slow when these patients are already developing very high levels of anti-nucleic acid proteins as well as the receptor binding domains of the spike protein. And so it's really not very clear that antibody responses and viral clearance don't seem to, the neutralizing responses are not very apparent. And we do know that in a study that was reported by Zhang et al. On 222 patients, they reported that severe cases were more frequently found in patients with high IgG levels compared to those with low levels. So it's the correlates of protective immunity for COVID-19 and it's still not very clear. Now, here's another study that shows the relationship between being RNA positive and having IgM or IgG levels. And in this particular case, the total antibody and the IgM antibodies are directed towards the receptor binding domain of the spike protein, and the IgG ELISA is directed against the nucleic acid protein. And we know from previous studies that both of those are correlated with neutralizing antibody. And yet you could see that from day 1 to 7 post onset of symptoms, in 94 patients, about 67% of those are still RNA positive, as 38% of them have started to develop antibodies. And from day 8 to day 14 in 135 patients, 54% of them are still RNA positive, but 89 or 90% of them already show that they have antibody levels. 73% have IgM and 54% have IgG. And then at 2 weeks or more post onset of symptoms in 90 patients, half of them are still RNA positive, even though 100% of them have developed antibodies. And so there are two lessons that we could take from there. Is one, that having a robust antibody response using these assays does not always mean that the patient is not shedding virus, although, as we had said before, being RNA positive does not always equate to the patient shedding live virus or continue to transmit. And so the second message from this work is that if you could use an RNA test and an antibody test, you could actually increase the sensitivity of detection in these COVID patients much earlier in terms of days after onset. Now, on the 8th of April, WHO has issued an advice on the use of point-of-care immunodiagnostic tests for COVID-19. And by immunodiagnostic tests, they mean that a test to detect viral antigen, as well as a test to detect a viral antibodies in response to the viral infection. WHO applauds the effort of test developers to innovate and respond to the needs of the population in developing these antigen and antibody tests. However, they feel that these tests must be validated in the appropriate populations and settings, and that inadequate or suboptimal tests in terms of test performance may miss patients with active infections or falsely classify them as having the disease when they don't, therefore hampering disease control efforts. So currently, WHO does not recommend the use of these new point-of-care immunodiagnostic tests and would only recommend them to be used in research settings and not for any other settings, including for clinical decision-making. And so this will be updated when there is more evidence to support their use for COVID-19. So we started to do some research to think how we could use especially these rapid immunodiagnostic tests. Before we consider what research we could do to understand that the role of immunodiagnostic tests can play in the COVID-19 response, let's look at diagnostic tests in terms of their accuracy, accessibility, and affordability. I usually call these the 3 A's because no test is perfect. And so in trying to choose a test, we need to look at the trade-off between accuracy, accessibility, and affordability. And so you could see that molecular tests are highly sensitive, highly specific, but they are not very accessible because they require a lab with sophisticated equipment, highly trained technicians to do the test, and it usually takes at least a couple of hours to get the results. And also they are quite expensive compared to the other tests. Now, there are molecular tests that are now point-of-care tests, which means that they retain the accuracy for lab-based molecular tests, but they are now sample in, answer out type of tests where it's a seal unit and the entire procedure can be done without highly trained laboratory staff. So it takes a few minutes of hands-on time to process a specimen and put it into the device, and the answer will come out in anywhere from 5 to 45 minutes. But they still are relatively more expensive than either antigen or antibody tests. At the moment, we don't have any antigen tests that are really sensitive enough or specific enough that could be used in place of molecular tests. And so in many countries, what we're left with is that they are either unable to afford molecular testing, or they don't have enough infrastructure for lab infrastructure to be able to do the volume of tests that are required because of patients coming in with symptoms consistent with COVID-19. And so either you have a long queue of patients waiting for their results, and in some countries it's thousands of samples that are backlogged. So patients are waiting a long time to get their results, or they, in some areas, they don't have access to labs at all, so there's no testing being done, or that they have run out of stocks for swabs or reagents. So I think it's really important for us to be able to think how we could innovate on the use of serology tests for this COVID-19 response. And so we thought of some possible uses for rapid serology tests. First, to do a rapid triage of suspect cases in the community. Second, to test contacts of confirmed cases. Third, to do a situation analysis and surveillance to monitor disease trends. Fourth, to discharge COVID-19 patients who have recovered, and in many cases, hospitals do need the beds for patients, and so is there a way that we could use serology tests to discharge a patient from the hospital? And finally, the idea of an immunity passport for healthcare workers or critical infrastructure workers to return to work after they've recovered from their infection. And so first, I'd like to give an example of how rapid serology tests are being used for rapid triage of suspect cases in Peru. Peru has a population of 32 million with limited molecular testing facilities and only 500 ICU beds. The government has put up a hotline for people to phone in and a website where people can connect if they have symptoms that are consistent with COVID-19. They will be, when they reach somebody on this hotline or on the website, they will undergo a short interview with a health professional, and a visit would be arranged for testing the symptomatic person and any other contacts in the home. And the schedule is to prioritize testing according to age, so prioritizing those who are elderly, those with risk factors, such as underlying conditions, and those with severe symptoms. And so a team would arrive in the home of the caller and do testing with a rapid serology test, testing for IgM and IgG. Now, those who are positive for IgM and IgG, and usually those, as I showed before, those two antibody responses for COVID are very closely linked, and so they tend to become positive almost at the same time. And so for those who test positive, whose symptoms are mild, they're quarantined at home or just taken to a quarantine facility. And those who are critically ill and need critical care are referred to a hospital. Those who test negative, we think that they may be in the period where they are still in the period of viremia, and so a swab is collected from them for molecular testing. Now, as of April 18th, more than 135,000 people have been triaged, with 14,000 positives being identified. This approach has really allowed a large number of symptomatic individuals in the community to be rapidly tested, and therefore relieve the backlog and the waiting time for molecular testing, as well as preventing the healthcare system from being overwhelmed. Now, for testing contacts of confirmed COVID-19 cases, studies have shown that a large number of infected individuals may only have mild symptoms or no symptoms at all, but they can still shed virus and transmit infection. Experience from Singapore in the early days of the pandemic had shown that tracking down all contacts of confirmed COVID-19 cases is really important. Because once they test positive, they should be put into isolation, and that way you could then make sure that you could contain the epidemic, especially in the early stages when there are only sporadic cases or clusters of cases. So testing all contacts of a confirmed case, regardless of symptoms, is critical in interrupting the chain of transmission in the community. So those who test positive should self-isolate, and those who test negative will have a throat swab collected for molecular testing. For situation analysis and surveillance, this is a very common use of serology tests for viral infections. And so in a lot of countries, after the flu outbreak of 2009, WHO has helped a lot of countries set up influenza-like illness surveillance program or national influenza sentinel surveillance systems. In some countries, they've also set up, since SARS, a severe acute respiratory infection surveillance system. And so if you use a serology test to test the samples collected from those sentinel sites, you would have an idea of how many patients, if any of these samples test positive, you know that COVID-19 has been circulating in the community. If these samples that are collected are indeed representative of a population, then testing with the serology test would allow you to estimate the true extent of the pandemic, map the geographic distribution of where the pandemic is has hot spots or where they are still not in circulation. And if you know the of those who have symptoms, we could determine the attack rate and the risk populations. And then with surveillance, you can monitor trends over time and be able to adjust your public health measures accordingly. Now, with regard to the use of serology tests as a criteria for discharge of recovered cases from hospital, normally we say that the optimal criteria for hospital discharge for COVID-19 should be 2 negative molecular tests over several days. Hospital beds are usually in short supply, and molecular testing in some facilities may be very limited or not available, or that the patients will have to wait a long time for the test results. And so use of serology tests may be useful in this case, but because we know that some patients remain RNA positive despite having rising levels of IgM and IgG antibodies, then we're not sure whether virus replication has stopped or not. And because the sample size of those studies were very small, so there's a lot of uncertainty regarding virus shedding in these patients, despite the fact that they may be IgM or IgG positive. So we don't really recommend the use of serology tests as a criteria for discharging patients who have recovered from hospital. Now, in terms of immunity passports, I think that there's always been some way that we want to be able to determine when can critical or essential workers, especially healthcare workers who have recovered from COVID-19, when can they return to work? Now, we know that we would like to think that when they have, when they test positive in a serology test, maybe it's a sign that they've developed protective immunity. But because we know from the studies we've presented previously that COVID-19 patients can actually remain RNA positive despite rising levels of neutralizing antibodies, and that IgG levels may be associated with severe disease, we still really don't understand protective immunity for COVID-19 disease. Hence, what kind of tests can we use to give someone an immunity passport remains unclear. Now, the World Bank has put out a policy brief to say that in this pandemic, we need 2 types of tests. The molecular tests, we all know, which could be used to confirm cases in people who are symptomatic, and also, they said, an antibody test. So their contention is that if we could have antibody tests that would show that the person can safely return to work, and if this antibody test would allow 1/5 of those who are immune to return to work early, the gain could be about 2% of the national income. And in the case of a country like Philippines, about $8 million. And so there is really a very compelling reason to develop good antibody assays that is a correlate of protective immunity for the COVID-19 response. And so this is something to really keep in mind as we think about the use of rapid serology tests. So in summary, I like to say that we think that there would be possible uses of serology tests in a rapid triage program for suspect cases in the community, to test the contacts of confirmed cases, and also for situation analysis and surveillance. we currently do not understand enough about antibody responses to be able to recommend the use of serology tests for the discharge of COVID-19 patients from hospitals, even when they have recovered clinically. And we don't recommend the use of serology tests as an immunity passport for healthcare workers to return to work. I'd like to end by acknowledging many very, very useful discussions on this topic with my colleagues at the London School of Hygiene and Tropical Medicine and the International Diagnostics Centre, David Heyman and Debbie Boras. And I especially like to thank Catherine Wedderburn for extracting all the data together with Noah Fongwin from the school. I also like to acknowledge the leadership of John Nkengasong at the Africa CDC in this pandemic response, and also Yenew Kebede. And Amadou Sall from the Institut Pasteur de Dakar, who's been a long-standing collaborator. I'd like to thank ASLM for also very useful discussions here, and with our colleagues at FIND, and especially thank Patty Garcia for this very good example of how to use serology tests for triaging suspect cases in the community, and she's at the Cayetano University in Peru. I also like to thank Amilcar from the Federal University of Rio de Janeiro in Brazil, Wong Sao Chin, and many others for very, very good discussions on this topic. And we will continue the research on this work. Thank you.
Thank you very much, Rosanna, for the presentation. It's probably what has been said around on the internet with the increase in numbers. But all the same, beautiful presentation. Today we will have a little bit more time than the usual 1 hour, so we will have enough time for questions. So after Rosanna, I'd like to call upon Dr. Yenew Kebede, who's the head of laboratory services at the Africa Centers for Disease Control and Prevention. And he's going to share with us what Africa CDC has been working on. I will share the slides on his behalf. Just a second. All right. I hope I'm not also compromised. All right. So there you are. Yeah. Yenew, over to you.
Okay. So good afternoon, good morning, wherever you are, everyone. I would like to appreciate Professor Rosanna. I think most of the people here, we have at least, we have clearly, the information about antibody test, what we can use for and what we cannot. Because I think that question has been really coming to us from different angles. So we really appreciate rich information that was presented in this session. Thank you very much. So mine will be, let's gear into the program, what we can do in Africa. Next slide, Anafi. So testing, you have heard it, everybody is screaming for testing. Because especially, in early phase of the epidemic, testing is very, very important. You have to isolate, you have to identify the case and isolate the case, quarantine contacts. That's a very important and powerful tool to really control this epidemic. Therefore, everybody has to do testing, especially at the early phase of the epidemic. So in line with that, Africa CDC launched partnership for accelerated COVID testing, which we call it PACT. This is testing and tracing. So this one is looking to conduct 1 million tests in the next 1 month. I know these are ambitious numbers, but countries have to aspire to do this. And then it requires establishment of an Africa-wide pooled procurement system to supply member states with the necessary tools to do the testing. And then after the testing, there has to be also tracing of contacts. So for that, Africa CDC is proposing deploying of 1 million healthcare workers across the continent. How to do this? We are discussing with many partners and member states, so hopefully we can do this. Next slide. So let's see, some of the examples from other parts of the world. So the scaling up testing, as I said, it helps to identify and isolate cases, especially those that have mild symptoms or those which don't have symptoms at all. And then there has to be a robust contact tracing, especially as countries remove some of these lockdowns. And then the testing will help also to uncover areas of concentration of cases. And then it will empower countries to implement targeted measures so that we can limit, economic and social harms by locking down the entire country. And then it allows for better insight into spread of the disease. So let's take the lessons from South Korea. I think you have, some of you who have attended the similar webinar last time, you have seen how South Korea has been ramping up testing. So South Korea has been doing 15,000 tests per day. And following massive numbers of cases in Daegu, the case growth is now flat because, they were really tracking everybody, testing, isolating. So if you see, the South Korean curve, it's really unique. So Iceland has tested 10% of its people, but it has identified 1,770 cases. But we are also, cautious that testing should not be for the sake of testing. It has to be a little bit of targeted in identifying cases. So, and then if you see, the case of USA, I think there was initially very slow rollout of testing. And I think because of that, you see, today, US is the epicenter of the outbreak. Next slide. So let me show you where we are today. Despite incomplete data collection from some of the countries, in the African continent, there is 500,000 tests that's done today. If you take that one per million population, so it's only 375 per million population. So the PACT proposed to do this, to expand this to 1 million tests by the end of next month. That is equivalent to around 800 per million population in Africa. And then if we achieve, in the next 4 or 6 months, 10 million tests, so that will be 8,000 tests per million. But the whole idea is to reach 16,000 tests per million. And if we see, the per million testing level by other countries, Italy has 21,000 tests per million, US has 12,000, and South Korea has 11,000. So Africa, with a population of 1.3 billion, we are still at 375. So the whole sense of this initiative is that we need to do more in terms of cascading the testing. Next slide. So how can we do this? Let me share you the idea from the Africa CDC side. In fact, it requires collaboration by many actors. So Africa CDC, to really support the scale-up of testing, we will be distributing 1 million test kits as of, in fact, we have started, but we will be distributing 1 million tests in the next 4 weeks. So far, we have back, Anafi. Can you go back, Anafi? One slide back. Okay. So, and then we are so far, we facilitate distribution of 1 million test kits from the Ethiopian Prime Minister and Jack Ma Foundation Initiative, and Africa CDC from our own supply. We also distributed 78,000 tests. But as I said, in the next 4 weeks, we will distribute 1 million. And then we want to set up in collaboration with many other actors, an Africa-wide pooled procurement system where it will be easier to distribute to member states. And then in terms of capacity building, we have ongoing training programs. Actually, it's virtual. And then we are working, with the human resource team to deploy lab experts. And we would like to facilitate also engagement with the private sector in terms of using other alternative testing platforms, including, the Cepheid, Roche, Abbott. And then we would like to engage with private labs to scale up testing capacity. And then some of the discussion points that we had with Professor Rosanna's presentation, if we found the antibody, especially good characteristics in terms of performance, I think we are still discussing a technical working group. Most likely, Africa CDC will issue an interim guidance on how to use antibody testing, because we feel that it's critical to facilitate the testing cascade in Africa. Next slide. So I think you may have seen this. So we have, in line with this initiative, we have also issued a testing strategy for the continent. For countries which are from phase 0 to 2, I think these phases from WHO guidance. These are with no or limited community transmission. For those countries, our recommendation is that anyone with fever and acute respiratory symptom based on WHO case definition should be tested. All symptomatic contacts of confirmed or probable case should be tested. I think many countries are finding that even people without symptoms are turning to be positive for COVID. I think we need to consider that as well. And then all SARI cases presenting to hospital in a place where circulation is expected should be tested. And then we recommend, healthcare workers with symptoms consistent with COVID disease, regardless of the exposure, to be tested. If it's widespread, phase 3 to 4, where you have, community transmission already. So we are recommending, all severe acute respiratory infections to be tested, healthcare workers, and then additional testing in areas where there is high likelihood of rapid acceleration in transmission. Example, like, densely packed communities, areas with poor sanitation and so on. Those should be subjected for testing. Next slide. So, to complement this effort, as I said, in addition to massive testing, there has to be a robust contact tracing, which is key to contain the outbreak. So, Africa CDC is recommending and is working deployment and training of community health workers. As I mentioned, the aim is to deploy 1 million. And then engagement with technology companies to support the deployment of tracing technologies, for example, mobile apps, and then setting up of surveillance data systems at member states emergency operations center by deploying technical experts. This complements, the massive lab testing to really make the use of every test result to really contain the epidemic. Excellent. Next, Anafi. So in terms of partnership, as I mentioned, it's important to engage the private sector labs to supplement government testing capacity, and then provide support on logistics of sample collection and transportation. For example, can we set up mobile collection centers, especially to reach, peripheral sites, refugee communities, and so on. And we are also engaging, local institutions for scale up of capacity of local manufacturing. A good example is KEMRI has come up with some sort of combined antigen and antibody testing. Maybe we may need to evaluate that one quickly, and then see, how that can help the continental testing strategy. I know Morocco is doing the same. There are also some others, Institut Pasteur de Dakar is engaged in doing some manufacturing. So I think it's really critical to really support, continental effort of local manufacturing of key commodities and diagnostics, including infection prevention materials. And then we will engage, our partnership is also looking for deploying and scaling technology applications for support of contact tracing. And I think that looks all. Anaf, next slide.
That should be the last slide.
Yeah, I think that's the last slide. I think this is really, our message. We know, those numbers may look, unachievable, but I think we feel that that's the means to really come out of this pandemic. Thank you, Anafi. Thank you, everyone, for listening.
Thank you, Yenew. So before we go to the question and answer, we have Dr. Amadou Sall from the Institut Pasteur de Dakar in Senegal, who's going to give us the experiences from Senegal in terms of serology testing. Dr. Amadou, over to you.
Yes, thank you very much, Anafi, and thanks for ASLM for the fantastic job in putting together the webinar. Also for the great presentation from Rosanna and Yenew. I just wanted to give a perspective of a lab that are handling like hundreds of cases a day, because we are one of the lab testing in Senegal, and I just wanted to pick and bring to the attention like few remarks for the sake of time. Didn't bring any slides. Number one, I think it's very, very important that we all have in mind that we are somehow in a transition phase in Africa that may go one way or the other, but we are really starting in many of the countries, and there is a clear need to test more to be able actually to try to control this disease, because the whole idea is really to flatten the curves to remain under the capacity of the country to avoid the situation that we know in other places. And in this regards, we are in a phase where testing has been good, as Yenew just showed it, but need to be ramped up. The key question is how we can ramp it up. And in this regard, the two presentations has been very guiding and have been very important in these regards. And I just wanted to point two things. Number one is the real needs to make sure we have some good performance rapid detection tests. And this is something important in the sense that so far we have several tests. WHO have been extremely vocal in that. And there is really to make sure that we evaluate the tests properly before moving them. And I think this is a very important message, and that's why, as a lab, we are investing a lot of time and effort to make sure that we have good panels and we have good samples in terms of biobanking correctly, and also using the different samples to make sure we have a good evaluation, whether we're talking about antigen test or antibody test. And this is one very important message, because all the lab listening should probably have in mind about these steps are going to be very important to move to the scaling up, because the serology test may be a very good option where we can, if you want to expand the testing. The second important message I just would like to also emphasize that in this period of transition, there is key things that we need to have in mind. Number one, resource in terms of tests are tight and going to be also going to be tight, even though there are a lot of effort to make sure Africa are going to access to that. This has to be kept in mind, because nowadays I know some countries we cannot test anymore because they run out of tests. So, which is something we have to keep in mind. And the way I'm saying that, even though we're going to serology or we're using molecular tests, we have to rationalize them and make sure we use them in the best case context where it's going to help supporting actually the control. The second important aspect, even though serology may be in terms of RDT quite easy to run, we need a little bit of training to make sure that they're well kept, they're well deployed, and reading system are very, very well actually understood by the different labs, because this tends to go beyond just the labs. And this part of training is something we have to keep in mind. That's why, in collaboration with Africa CDC, WHO, and all the partners, we are developing more and more at the lab and ASLM opportunity to do some training and distant training, because this is something that's going to be also key. The third part I wanted also to mention is that even though serology is really great and going to help us a lot, we have to keep in mind that combining them would be extremely important in some context. So in the context of rationalizing resource, and at the lab we're seeing more and more happening, and somehow decentralization at the country level, finding a good combination may be a good strategy, as Rosanna showed that in some contexts you can have 100% people being captured just by wisely using these two molecular tests. Now, one last important comment I wanted actually to make is really think about these three cases, and I'm happy that because we took some time with Rosanna and other partners to build those. The rapid triage is really something we have to keep in mind, because it's going to help a lot about the number one trouble we have with lab, what's happening in the community. Having a system to triage is absolutely critical to be able actually to do such a kind of work. The second part is the contact tracing, which is today one of the number one challenge that many countries are having to avoid community cases. Using those in such a context would be absolutely important. That's why in order to strategize that, having these three components working together would be very important. And the last part concerning surveillance is very important also to know where we can allocate resource. And in all these three strategies, the preliminary is to have good system to make sure you have reasonable performance, and second, to make sure actually people are trained to do the contact tracing and surveillance correctly. Now, the last point I wanted actually to touch is the necessity to build self-reliance when it comes to diagnostic tests. And I want to touch some initiative we're having currently where the whole idea has been built to develop rapid tests, and the COVID-1 prototype is actually under development, with the focus in Africa and to be able actually to deliver it to different countries at the cost which is going to be the cost of goods. It's important that we have this in mind, because the whole idea is really to make sure within Africa we have a good opportunity to do the supplies. Now in Senegal, to describe a little bit the situation, there has been a situation where very aggressive measures have been put by the government at the very beginning of the epidemics, and that really slowed down a little bit the way that the cases are raising. And right now we are in a kind of second phase where, and close the border. And right now we are in second phase where we have more and more community cases, still cluster, and a ramping of the testing that can get more test positive, among which the majority are among the contacts that have been followed. And in such a situation right now, there's a discussion, strategy discussion about how to run that, and obviously getting more molecular tests being done, but also being in a position to be prepared to use all those rapid tests, whether it's in terms of ELISA to do like more a sero survey, or using RDT in the 3 different cases that I mentioned. I'm going to stop there because I've seen a lot of questions coming, and we'll be happy to contribute anyhow into discussion. Over to you.
Thank you, Dr. Sall, for those important perspectives, indeed. So we get into the question and answer segment, and I'm going to quickly take the questions as they have been brought into here by my colleagues. The first one is from, I can't read the name properly, but he or she says, this reminds me of the HIV and antibody response. So it is new information. Please let me know. I think it's a comment. The other one is from Patrick Swai. He says, is COVID seroconversion, is seroconversion of COVID different from that of SARS, MERS, HIV, and Ebola, or other recent epidemics? Please clarify. Is COVID, is seroconversion of COVID different from SARS, MERS, HIV, Ebola, and other recent epidemics? Please clarify.
This is Rosanna. I think, as far as I know, I think the seroconversion is much faster than SARS. But of course, we have a few studies from SARS in terms of neutralizing antibodies, that some reports that they only last about a year, some reports that they last for years. So for COVID, we still don't know, because we're just over 100 days at the moment from when we first knew about this virus. So I don't really know. Amadou? I think Amadou is muted.
Let me unmute him.
Yeah, could you unmute?
Amadou. There you go. All right.
Yeah, thank you. So totally aligned with you, Rosanna. I think the process is the same, probably in terms of earliness. What we're seeing so far, to our knowledge, is just it's a bit earlier from what we know from the other viruses. Over to you.
Thank you both. There is also another one from Lisa. What could be the reason for the severe cases with high IgG levels?
I think from what we know is that there are some patients who make what we think are an atypical response or inappropriate response, in that their immune system kick into high gear. But these antibodies that are produced are not necessarily neutralizing antibodies. And so we just don't know enough about these antibodies and why in some severe cases antibodies coexist with a bad outcome. Amadou and Yenew? No.
Okay, Amadou, I've unmuted him.
Yeah, nothing to add. I mean, that's totally what I am totally in line with that. Nothing special to add. Over to you.
All right. Thank you. There is a question for Dr. Yenew here from Cathbed, who says, thank you very much for the coordination, and that is much appreciated. As you finalize the food procurement, please consider decentralizing procurement to boost and develop existing distributing businesses. We risk destroying systems that we are supporting diagnostics in countries. I think it's more of a concern. Cuthbert says, as you finalize food procurement, please consider decentralizing procurement to boost and develop existing distribution businesses as we risk destroying these systems that are supporting diagnostics in the country. It's a comment from there. Maybe you want to respond, Yenew?
Thank you. I think that we accept the comment, but I think our concern now is how can countries get supplies and test kits as quickly as possible as they struggle with this epidemic. Because the usual distribution mechanism and so on with lockdown of most of the countries doesn't work. So I think we need to think out of the box and then see other mechanisms. For example, we're trying to use DHL, but I think it's becoming even difficult for them. So last time, they couldn't deliver test kits for more than 8 days. So I think that's why we are trying to use maybe negotiating with member states to get military planes or using other cargos in the continent. So I think this is a very difficult time and really doesn't give you even time to think. Yeah, this is difficult, but I think we take the comment.
Thank you. Whilst you are there, question from Ernest Makoka. Ernest says, what is the formula? What formula is Africa CDC using to distribute kits? And then he goes on to say, what platform will be used for testing? How will the quality of testing be assured across testing labs in Africa?
Thank you. I think that's very, very pertinent question. When we do all these distributions, so Africa CDC has done a modeling, coming up with the expected number of infections based on population, the current infection rate, and so on. So for each member state, we do have a projected number of tests that are needed. So based on that need, which almost is a very objective evidence, so proportionally we devise the test kits based on that formula. And then in terms of the platform, so currently we are distributing the PCR, the manual PCR platforms. These are both extraction kits and detection kits. Sample collection materials, virus transport medium, but we are now engaging ourselves with the global consortium to discuss on the African share from the international quantification for GeneXpert, automated Abbott platforms, Roche platforms. So I think in the next weeks or so, countries will start also getting those platforms. But our main focus so far has been on the manual PCR platforms.
Thank you for the response.
So in terms of quality, sorry, Anafi, in terms of quality, so we are working with WHO to enroll laboratories into PT program. And then we are also discussing with Professor Rosanna Pascal from ASLM, Amadou, Dr. Amadou, to really roll out the EQA program for the PCR testing labs. So I think labs will start hearing more from us on that.
Thank you very much. Another question on serology. This is from Franklin. Franklin says, do we have preliminary serology testing data from Africa? Preliminary data elsewhere, such as in the UK, indicated that antibody tests were only accurate in severely ill patients. Rosanna and Amadou.
I think that Amadou knows more about this than I do. At the training workshop that we did in February, some of the virologists who had been working in Africa had said that the coronavirus that's circulating in Africa, the seasonal coronaviruses, more alike in terms of genetic, I guess, closeness to the MERS-CoV virus, coronavirus. So I don't know if that could become a low level of cross-reactivity for serology tests. So that's why we need to make sure that we conduct we have good panels to evaluate the specificity of the serology tests before they're deployed. Amadou?
Yes, I just wanted to mention, so far in Africa, I'm not very much aware of any data concerning severity and increase of antibodies. So far, I haven't seen anything. Maybe some people are more aware, but to my knowledge, there is no data. Concerning the other areas, we're talking about SARS-CoV-2, right?
Yeah.
Concerning the other areas, also, this has been quite well. There is few data summarized by Rosanna, where we're talking more about the earliness in the highest level. That's in the presentation, which is the general trend that we would see so far in the paper that came out. Over to you.
Thank you, Amadou. Maybe I will probably take one more question, and this one comes from Z. It says, antibody RDT picks non-active cases when we can't even thereafter put people in quarantine or isolation. What guidance are we saying exactly, given that many countries are using these RDTs and WHO plus other institutions are against their use at the moment, especially as there is no independent data on their performance and they are not yet FDA or WHO approved? The mouthful. Yes, go ahead.
Okay, so I would like to say that there's been a lot of news stories and a lot of different position statements about the, advising us not to use serology tests until we understand a little bit more about the immune response, as well as understand a little bit more about the performance of the test. I think the main concern has been that if the antibody tests turn out to have lots of cross-reactions with the common seasonal coronaviruses or other viruses, then when you use these serology tests in a general population, where the prevalence of infection may be very low, like 1% or even less than 1%, then you're going to see a lot more false positives than true positives. And so it's very important that when you think about the use of these tests, I think in all what we recommend is to use them first in symptomatic cases where the likelihood that they'll be positive for COVID is a lot higher. And that way, we could circumvent some of these limitations with regard to true positives versus false positives. And even for context of confirmed cases, there's a higher likelihood that they could be positive compared to the general population. And so, in order for a test to be used in the general population, there has to be very, very high specificity. And I think we're not there yet with regard to any of the current tests that we have.
Thank you, Rosanna. Amadou, you want to speak to that?
Yes, just want to say that it's very important, even though we know we are all desperate about having this testing, to rely on good tests and with performance that has been evaluated. Because, having a bad lab or a bad test is worse than not having a lab at all or a test at all, because it leads to wrong decision, and that may end people that kind of using capacity that would be very helpful in the context of this epidemic. So I think in the coming weeks, we may have some tests with reasonably good performance that can be used. And I would really strongly encourage to make sure between now and then to try to work out what is existing to the effort that all these people are putting together to make this test available.
Thank you very much for those remarks. I think they take us really towards the end. Rosanna, in 30 seconds, any last remarks?
Yes, I really look forward to the results of evaluations of all these rapid serology tests. I know there are a huge number of them out there, and we need to sort out which are the good ones. And I'd like to say that WHO is developing target product profiles to guide us as to what would be the expected performance of these different tests, from PCR to antigen detection to antibody detection, so that we have some idea of what would be minimal and what would be ideal in terms of test performance. Thank you.
Thank you, Rosanna. Amadou, any last remarks in 30 seconds? I think he's muted there. Maybe Yenew, in 30 seconds, last remarks.
Yeah, thank you, Anafi. Thank you, ASLM, for the opportunity. I think I found this to be very, very helpful. It's synergistic with what Africa CDC is trying to do. So I would like to really ask the support of all of the laboratory community that are attending this session. Really, to support this initiative. We feel that that is the only way out for this continent. We need to do more testing. We need to isolate cases as early as possible. Testing may not be even important at advanced stage of the disease. It is this time that Africa needs more testing. So I would like really, everybody's effort to really support this initiative. Thank you.
Thank you, Yenew. Amadou?
Yes, just wanted to say that we are in a transition phase again, and we need to take this time to make sure that we are getting ready for having more of these tests at high quality level being available. And in this regards, there is also some initiative to do EQA for serology, which is done by WHO, Africa CDC, and all the different people, which are going to be as important are having EQA for that. And really the quality is what we should be actually focusing on and performance for this test. Over to you.
Thank you, Amadou, Yenew, and Rosanna. And just in closing, like as Yenew mentioned, it's time for us to be testing and more testing. And I'll repeat testing again, as we said at the beginning. But this testing only will not be enough. It will only be enough if the results of the tests are delivered to where they are supposed to be used timely. And this will be the subject of our next special session, which will be coming on Tuesday. We will be sending the invitations soon, so look out for those, and we hope to see you again. Till we meet, we will say goodbye and enjoy your evening, morning or afternoon. Thank you very much.